practice. Don't hold it against me. All right, yeah, but there we go. Let's see if I maybe use this. There you go. I'll just speak up. How's that? Is that better? I'm from Texas originally. I did my medical school training in San Antonio. And then both me and my wife wanted to pursue postgraduate training. She did pediatrics and I wanted to do surgery. So we ended up finding a place in Omaha that we both were happy with. So I stuck around there for several years, and then I ended up doing a transplant fellowship. And my mentor at the time was Dr. Botha, whose big interest was actually in neuroendocrine disease. So he decided to actually go back to South Africa, and that left the spot open, and they asked me if I'd like to stick around, and so I did, and also kind of continued to pursue his interest in neuroendocrine disease as well. So with that, I'll go ahead and get started. So this talk is mainly going to be a review and update with regards to neuroendocrine tumor management. And here are the team members, myself. Dr. Grimm is the oncologist in our clinic. Our clinic meets every other week on Friday afternoons. Lucy is again the boss of the clinic. She kind of lets us know where we need to be, what we need to do. But again, the one thing I want to do stress is she's actually the most vital component of the clinic, just because she is the person that individuals speak with and coordinates all your appointments, studies, and whatnot. She's a great resource, and without her, I don't think the clinic would actually thrive like it is. And Haiti Armstrong, she's our PR director and stuff like that. Financial disclosures, none. I just want to start with two definitions, just to kind of keep in the back of your head, so that way while we go through this talk, just keep those in mind. So cancer is uncontrolled growth of abnormal cells in the body. Disease, it's a disorder in the structure or function of the human body that produces specific signs or symptoms. Just keep those in mind. Neuroendocrine tumor. So the classification for neuroendocrine tumors can vary. Some people classify it as functional versus non-functional. It can be based on location, hindgut, midgut, etc. And then there's also staging of these particular tumors. This is again an outline. Diagnostic studies. I'm going to talk about interventional management, surgical management, as well as chemotherapeutic options, and then briefly some trials that are ongoing. So classification of the neuroendocrine tumors, functional or non-functional. So functional tumors, we often think of patients who have carcinoid syndrome. But other classifications of neuroendocrine tumors are pancreatic tumors that have actually glucagon, secrete insulin, secrete somatostatin. That won't be the focus of this particular talk. And then we have the small intestine, such as your carcinoid tumors or tumors that secrete somatostatin, 5-HIA, and whatnot. And then you also have non-functional tumors. These particular tumors can be both of the pancreas or the small bowel. They just do not secrete particular hormones that have some sort of clinical manifestation. They do secrete proteins and hormones, but to the effect that they really don't manifest any types of symptoms or signs. So another way of classifying neuroendocrine tumors is based on their location. They can be in the midgut, foregut, or the hindgut. And this is just a cartoon drawing based on the vascular distribution of particular organs. So in the embryo, you have what we call the celiac axis. That's the main blood vessel that supplies blood flow to the foregut. Then you have the superior mesenteric vein that supplies blood flow to the mid portion of the intestines. We call this the midgut. And then you have the hindgut, the inferior mesenteric artery. And then again, here's your distribution. So the celiac axis provides blood flow to these structures here, the pancreas as well. Superior mesenteric artery to your intestines, while the inferior mesenteric artery provides to the distal 2/3 of your colon down to your rectum. Again, the pancreas is found in the foregut. Small bowel is in the midgut. And when it comes to neuroendocrine tumors, most of them are actually found within the first 60 centimeters of the terminal ileum. This is the last portion of the small bowel, right before it actually enters into the colon or the cecum. And things that we as surgeons need to keep in mind, just because we identify one particular tumor in the small bowel, we have to be fastidious and make sure we don't miss other tumors that can be present at the same time, because there's a 25% incidence that these tumors are multifocal. This is a very busy slide. The goal was not to inundate you with the nuances with regards to the staging, sizing, and whatnot. When it comes to neuroendocrine disease, it's all about, is it metastasized or is it localized? That's pretty much where you can kind of break it down. If it's localized, it's a great situation because you can provide surgical management or surgical therapy where you can resect that primary tumor and not really have to deal with the metastatic portion of it. If it's metastasized, then it can become very problematic depending on the degree of metastasis, location. Again, with neuroendocrine tumors, as you all know, they have a propensity to actually metastasize to the liver. So again, the biggest thing with regards to staging, is it local, has it metastasized, and another important factor, as you also know, is with regards to grade, the Ki-67. Is it a high mitotic rate or is it a low mitotic rate? The importance for that is its natural course of the actual disease. If it's a low mitotic rate, this is a particular neuroendocrine tumor that's going to actually hopefully just continue to progress slowly. And if with appropriate medical management, we can actually make it somewhat stagnant. Versus a mitotic rate that's actually high, these particular tumors have a very aggressive type of approach. Diagnostic, sure, go ahead.
Can you just comment on low versus high? What would a number range?
So what we usually look at, less than 2 to 5 intermediate, and then greater than 5 to 10 would be high. So those are the ones that's kind of like the mitotic rate, where the pathologist will actually look at the tumor itself and see how many of those particular tumors are actually actively undergoing division. So that's what we will look at. So, sure. Any other questions? I have y'all speechless.
Just to follow up to that question,
Sure.
does each tumor have a mitotic rate?
Mitotic rate, yes.
Mitotic rate.
So when we actually take these tumors out, we actually send it to the pathologist, and we all, not myself, everybody that has that is involved with neuroendocrine disease, will ask the pathologist what the Ki-67 index is, because we want to be able to prognosticate, to tell our patients, you know what, this is what you're looking at, and this is the particular type of tumor. Things of interest is also that the primary may have a different mitotic rate than the actual metastatic lesions as well. So that's something else that we look at. So say somebody comes in with an ileal primary with metastatic disease to the liver, we'll take out the terminal ileum, and then we'll also take out whatever disease they have in the liver, and then we'll send Ki-67s for both. Again, this is all with regards to prognosis, so we can tell our patients, you know what, this is a low mitotic rate, and this is what we expect from this particular tumor and whatnot. Question?
What does the distribution of rates look like?
What's that?
The distribution of rates looks like? Is it like normally distributed, or?
You mean with regards to the Ki-67?
Yeah.
If somebody, it's the majority of, I would say probably about 85% of neuroendocrine disease is actually of the lower, kind of intermediate to low. It's very rare that we get a high. And if we do get a high, this is an individual that we've been watching for a while. And the natural biology of the tumor has actually progressed, so it's actually gone from intermediate to kind of a high grade, and it's just started to progress from there. So yeah. But the majority of these are actually slow growing. Yeah, it's a good question. Anything else? Any other questions? Sure.
Yeah, you said that about these tumors dividing.
Yeah.
I think I've actually got a couple of bigger ones that united.
That fuse? Yeah. Yeah. No, they just continue to grow slowly, and they just fuse. Yeah. You look pretty good for united tumors, though.
Is the mitotic rate predictive of metastasis at all?
We don't, I would, not necessarily in the sense that, okay, it has this particular mitotic rate. So are you asking if we find a primary with no metastasis and it's a high grade, do we worry about metastasis? Yes, yes. If it's a lower grade, then we wouldn't be too, not concerned, but when we follow these patients up, the expectation would be there would be no metastasis. Versus a person with high grade Ki-67, this would be somebody that, you know what, maybe after the first resection we're going to get scans every 3 months just to keep a very close eye on, because we would expect metastasis to occur. So yes, I would say yes. Yeah. And then once we kind of get a feel of what this particular tumor is going to be, the way it's going to behave, then we can kind of adjust with regards to our imaging interventions and whatnot. Any other questions? All right. So diagnostic studies. So we have CAT scans, we have MRI, MRI of the abdomen with MR interrography, we have Octreotide Scan, Gallium Scan, colonoscopy, upper endoscopy, and EUS. So, oops, what happened there? Here we go. So CAT scan and MRI. So these two modalities are the main ones that myself and Dr. Grimm used to figure out, well, where is this particular disease? When it comes to initial evaluation, what we do is most patients come to us with already some sort of imaging and whatnot. The CAT scan is a nice way just to kind of get an overall feel of how bad the disease is. Is it primarily from the small bowel? Does it have any lymph node metastasis to any other location? If we're dealing with somebody with a pancreatic neuroendocrine tumor that has some degree of metastasis to the liver, we actually prefer the MRI, because the MRI has a greater sensitivity of picking up smaller lesions within the liver itself as compared to CAT scan. So our preference is actually, if we're looking solely at the liver, we'll actually prefer an MRI. And oftentimes, as you know, sometimes you can actually have metastatic disease with an unknown primary. People show up to the clinic and you know what, they've got neuroendocrine disease in their liver and we just don't know where it came from. In these particular situations, we'll follow them up with some sort of diagnostic studies, and this is where the MR interrography comes in. Octreotide scan, again, Octreotide scan is a very nice scan because it can kind of give us a global picture with regards to where this disease is, because oftentimes the CAT scan may not pick up these particular tumors. The issue with Octreotide scan is the sensitivity. It's not very sensitive to picking up these tumors. Another caveat to that is these tumors need to be able to express the somatostatin receptors. Now, if you have a neuroendocrine tumor and it doesn't express these particular receptors, the Octreotide scan is not going to be worth anything because it's just not going to light up. It's going to look fine. Versus you having an MRI that shows that there's lesions in the liver, the Octreotide scan won't show anything. It won't light up. Again, the way the Octreotide scan works is it is actually bounded to a radioactive tracer. So once it actually binds to the tumor, that tracer just continues to give off radiation that can be picked up with the scanning device. The Gallium scan is actually a lot more sensitive when it comes to evaluating neuroendocrine tumors. Unfortunately, this hasn't reached mainstream as of yet, and as you know, there's very few Gallium scans in this area. We do not have a Gallium scan, much to our chagrin. Colonoscopy. Colonoscopy is a vital portion for the evaluation of patients with neuroendocrine disease. Reason being is because majority of these small bowel tumors are actually going to be located in the last portion of the small bowel. So an endoscopist can actually travel up through the entire colon, cannulate or get into the small bowel and actually look and see if he can actually find these particular tumors. He can biopsy them. They can actually tattoo these tumors, so when it comes time for an operation, we've localized where that particular tumor is located at. Upper endoscopy, again, same approach. When it comes to colonoscopy, you can actually visualize the stomach and the first parts of the small intestine. EUS is also vital in patients who have neuroendocrine disease of the pancreas, because here you can get really close to the pancreas, use an ultrasound probe, and actually scan the pancreas itself. They can usually pick up lesions about 1 centimeter in size, between 1/2 and 1 centimeter in size, and they can actually biopsy it during an EUS procedure. Any questions? No? How many of y'all have had a Gallium Scan? I'm just curious.
I've been recommended for one.
Yeah. No. How difficult was it to get the Gallium Scan in the back?
I went to the University of Iowa,
Yeah.
and it took quite a while, but they were just kind of doing trials at
Yeah.
the time, so I don't know where they are in the actual.
Yeah. I think they're still kind of in the trial basis and stuff like that. But yeah. Sure.
I did also.
Yeah.
It wasn't very difficult. It was very much like an Octreotide Scan.
Yeah.
In my case, it did not show anything other than the Octreotide scans.
Sure.
Didn't
Mine
show
didn't show
anything,
anything.
nothing in the intestine.
That's good. Did yeah. So it showed no difference from the Octreotide Scan.
Not for me.
Well, yeah. We've had some patients where it's actually shown a dramatic difference and stuff. So yeah. So, all right. And then markers. 5-HIA, chromogranin, and other markers. The use of these markers are not diagnostic. So there isn't a blood test that we can send, unfortunately, and say, okay, you know what, we can screen everybody in the country and we'll have a test to say, you know what, you've got a neuroendocrine disease. Unfortunately, they're not there yet. And I don't know if they're going to get there within my lifetime, to tell you the truth. Because, again, every neuroendocrine tumor is different. Some secrete particular hormones, others do not. And the rate at which they secrete is also different. But what these markers are good for is just to follow patients with regards to their endocrine disease. So we can get markers from the get-go, and we can watch them and see how they trend throughout their course. So they're nice markers, so again, just to trend the disease. Markers are going up, that's when we become a little bit more aggressive with our diagnostic imaging. Interventional management. So we have ablation, transarterial embolization, chemoembolization, selective intrahepatic radiotherapy, and then the indications. So this is work done primarily by the radiologist. The radiologist will go in there, and based on our recommendations, we'll talk to them and say, okay, you know what, this is what we think this person would most benefit from. Ablation, it's usually in individuals that have a limited amount of tumor burden within the liver, and that they can go in there, either ablate it with what we call RFA, radiofrequency ablation, actually just pretty much cook the tumor. They can actually use ethanol. Ethanol will denature the tumor itself, and cryotherapy, this is kind of freezing method. The difference being is that smaller tumors usually respond quite a bit. Smaller tumors, ethanol is a pretty non-invasive approach. It'll just kill that tumor, but its limitation is its size. It's usually about 2 centimeters. Anything above that, you're starting to get into the range where the ethanol won't really take care of all that tumor. Cryotherapy, this is where they freeze it. The nice thing about cryotherapy is it doesn't have a huge thermal effect. So when you put it in the liver, it doesn't dissipate a lot of the effects to structures around. Why is that important? Because the liver is a very vascular structure. Now, if your particular lesion is close to, say, what we call the portal vein, or one of the main veins that goes into the liver, cryotherapy is a nice way to try to treat that particular lesion. RFA, actually, it's great for larger lesions, but not so great when you're trying to control the proximity of the effect of the RFA. Transarterial embolization. So this is what we would call just bland embolization, where they use gel foams or particular beads. They'll go in through what we call the hepatic artery, and they'll actually find the blood vessels that are feeding these particular tumors, and they'll just shower that artery with these particular, this gel foam or these particulates. And that'll actually occlude the blood going to that particular tumor, hoping that that tumor will actually decrease in size. Transarterial chemoembolization, this is a type of method where it's much the same as bland embolization, but we actually, these particular beads actually carry chemotherapeutic agents, and we've actually had a pretty good response with patients who had large tumors with chemoembolization, that we can actually downsize these particular tumors and actually get them to resection. Selective intrahepatic radiotherapy. This is similar to chemoembolization, and with the difference being, instead of using chemicals, you're actually using isotopes. So these isotopes go to that particular tumor, and they sit there and then just release this radioactive energy that will kill the tumor. Again, its limitation is the size. The larger lesions aren't really going to do all that well or have a significant response. And there we've talked about the indications. Surgical management. This is what I have. So resection of the primary. So anytime we're dealing with neuroendocrine disease, neuroendocrine tumors, our number one goal is to decrease the amount of tumor burden that individuals have. As you know, most patients present with either unresectable disease, and in these particular patients, we try to get them to a point where we can actually resect their disease. Also important is what we call a lymphadenectomy. This is where these tumors have actually metastasized to those lymph nodes, and we need to be super aggressive in actually taking those lymph nodes out. And then liver metastasis. So there's the single-staged resection, and there's also the staged resection. So with the staged resection, there's a two-staged, and there's also what we call the ALPS procedure. Who's heard of the ALPS procedure? This is actually something that was just recently presented. So this is a diagram showing you metastatic disease to the liver and the way we can approach it with these various types of staged procedures. So here you have an isolated lesion in the liver, and here it's difficult to appreciate, but they've actually gone and embolized the portal vein, and it's allowed hypertrophy of the left lobe. And the whole reason behind this is because we don't want to take too much liver out. If we take too much liver out, it leaves you in what we call some degree of liver insufficiency, and that can be a horrible situation. Patients can either just eventually recover from the fact that they don't have enough liver parenchyma and they'll get better. The worst case scenario would be they actually go into full-blown liver failure just because they don't have enough liver to actually to deal with all the metabolites that their body's producing. And this is a very, very bad situation. So as a surgeon, this is something that we keep in mind and we always have to be aware of, because our initial intention is, you know what, we want to get rid of all the cancer, but we have to kind of be cognizant that if we take too much just because we can put the patient at risk. So this is just a staged hepatectomy where they see disease in both lobes of the liver. Here you see the right lobe and the left lobe. So they'll take out the right lobe, let the liver recover, and the liver will regenerate in about 6 weeks. And then they'll come back at a second operation and go ahead and take it out. Here's a different stage resection where they actually embolize the portal vein. This will be done by IR, and they'll actually take out lesions from the left lobe. And here you can see where those lesions are taken out. And at the second operation, they'll actually take out the other diseased lobe. With the goal of being, you know what, these patients don't have any measurable disease either by radiographic studies. And then here we have a different approach where they actually tied off the portal vein. This is where you do it intraoperatively. This is where you get it done by IR. So once you tie off the portal vein, that causes compensatory hypertrophy of the remaining lobe. So what ends up happening in this particular situation, the left lobe gets bigger, and at the time that they ligated, they took out these smaller tumors. At the second stage, they'll actually come back and take out the right lobe. So from, let's see, from B to D. The turnaround time for this, it's usually anywhere from, I'd say probably about 6 weeks to 2 months to do these stage operations. And from a surgeon standpoint, going back a second time is that much more difficult. Just because you've developed adhesions, things are difficult to actually dissect out. But here comes the ALPS procedure. This is associated liver ligation, where you actually transect the liver parenchyma at the first operation, and then you take out the smaller lesions in the remnant lobe, and then during the same hospitalization you let the liver hypertrophy and you come back and take it out. It's a mouthful. I'll break it down. So the whole goal for this ALPS procedure is that you come into the hospital, you're going to get part of the liver worked on, and then before you leave, that second stage of that procedure is going to happen. So what the goal is, so you get taken back to the operating room at the first operation, and then you take out the smaller lesions and the lobe that's going to stay behind. Here you can see the left lobe has minimal disease, but you know what? There's not a lot of liver left behind. That's the problem, like I was saying. If you take too much liver out, these patients can go into full-blown liver failure. So what's done at that first operation, they'll take those tumors out, and they'll actually ligate the portal vein, tie it off, so blood flow to the right lobe is only coming from the artery. And here's the difference. They'll actually transect the liver parenchyma. So then all of a sudden you have 2 separate lobes just hanging there in the body. Patient is actually closed up and then returned to the floor, and then within 7 days they get a repeat CAT scan to make sure that the remaining lobe has actually hypertrophied. The nice thing about this particular operation is the remaining lobe will actually hypertrophy that much faster when this is done, because what the thought is that all the growth factors are not going into that right lobe, they're just going into that left lobe, allowing it to grow. So anywhere from 7 to 10 days to 2 weeks, during that same hospital admission, that person actually gets taken back to the operating room, and then that remaining lobe gets taken out. Does that make sense?
Does that part grow back also or not?
Which part?
The last part you took out?
This here?
Yeah, well, you got the right,
This here?
that part there. You got
This does not, because the blood
once you
flow.
cut it off there,
Yeah.
it's gone.
No, it's still there, because the liver gets blood flow from 2 sources. One, the portal vein. The portal vein is the vein that drains all your mesentery, or all the intestines, goes into the liver. And then you also have the hepatic artery. So it's got 2 sources of inflow. The hepatic artery is maintained here. So it's not like the liver has 0 blood supply. It's still getting some blood. But the majority of the blood actually comes, 80% of the blood flow to the liver actually comes from the portal vein, where 20% actually comes from the artery.
Okay, then you go in and you take the last piece out.
Yes.
Will that grow back?
So this will not grow back. So when we're talking about the liver, what happens, this will grow.
That'll grow and take care of it.
Yeah.
So now you only got one lobe versus 2.
Exactly. Yeah. So you never, when you do these stage resections, you never grow the lobe back. The lobe never really grows back. All you really do is the lobe that stays behind, it just gets bigger.
Oh.
It just gets bigger. It's never that if you take the right lobe out, the left lobe out, those lobes will never come back. And the only thing that happens is that remaining lobe gets bigger. So it's not like you have a right lobe and then all of a sudden 2 years, 4 years down the road, that right side has more cancer in it, and you can't do another right lobe. What it really is the left lobe's gotten bigger and the right side come back. Does that make sense?
Very good.
How do you decide when it's big enough?
when you're rethrowing?
So what we'll do is, in these particular situations, you'll get CAT scans after that. And what we'll do is you'll actually measure the volume. There's a particular ratio that we know if we have a certain amount of liver volume compared to that patient's weight, that's when we know it's safe to go ahead and take that other part out.
So you look at liver function tests then?
Yeah, liver functions, so liver function test, you have your AST, ALT, your bilirubin, and then you have your clotting factors. So those are all liver function tests. So AST, ALT will be elevated regardless, just because you've divided the liver tissue, so you've had some tissue necrosis, and all that stuff will spill out into the bloodstream. That won't make much of a difference with regards, that won't be able to tell us is the liver ready to be taken out. Because again, like I said, you still have some blood flow, so this right side is still working for you. Not to the same degree as the other side, but it's still working. So we don't use liver functions as a surrogate to say, okay, you know what, it's ready to come out. It's mainly based on the volume, on the size.
So do you ever, when you do that procedure, do you ever see people have ascites after you've done that?
This procedure, I've never done, to tell you the truth. But it's just a natural progression from this stage. I'm actually very excited, to tell you the truth, about this particular procedure. So your original question with regards to the ascites. So ascites is a surrogate for portal hypertension. That's where the blood pressure going into the liver, there's too much resistance. So there's too much pressure in that portal vein right here. So it leads to high pressures in the mesentery. And as a way to kind of, as a relief valve to kind of diminish that pressure, is you start producing ascites. So the whole goal is to avoid that, because if you have enough volume, the resistance to flow into the liver will be so low, ascites won't be an issue. So no, that's the whole goal. If you take it, so if you do an operation such as a stage resection right here, where you take out the right lobe, and you were super aggressive, and then you end up just taking this part out as well, and you just left them with what we call segments 2, 3 here, this person would develop ascites, just because they don't have enough liver remnant to compensate for all that blood that's rushing through. There's too much resistance, and there's too much back pressure in the intestine, so you'll develop ascites. And these are kind of the signs that we look for when patients have inadequate liver function. So what they'll develop is ascites. They'll become what we call coagulopathic, where the INR actually starts going up, and they'll become jaundice or cholestatic, just because your liver is not able to accommodate all the requirements that the body needs. So then, yeah, it's a good question. Sure.
Is any kind of liver resection contraindicated if you have a clotting disorder like factor V life?
No. The only issue with those particular situations, it all has to do with risk. It's not a contraindication. It's just something that we have to manage intraoperatively and postoperatively. So if you have somebody that has a hypercoagulable state, somebody who has a propensity to forming clots, they're naturally on blood thinners, because again, they can form what we call DVTs, or clots in their veins, and the clots in the veins are problematic. The leg can swell, but most importantly, these clots can migrate. They'll migrate from the legs. They can actually migrate into the lungs, where they can actually cause huge problems. They can cause heart failure and death. So these patients are on blood thinners. So what we'll do, and what most people will do, we'll actually reverse the anticoagulation and put them on what we call either heparin or Lovenox, because most of the time they're on Coumadin or long-acting anticoagulants, so where they don't have to check their levels often. So heparin and Lovenox. Heparin you can turn off 4 hours, and you can be in the operating room, and you can be operating, and things will still be a little bit, blood will still be a little bit thin, but you can still operate in that setting. Lovenox you can shut off, again, 6 hours before. And so once you do the operation, you got to make sure everything's very dry during the operation, because the next day you're going to put that person back on blood thinning medications, and that's what you worry about. Now, if somebody had a very aggressive hypercoagulable state where they've had multiple PEs and it's really bad, in these particular situations, I'd probably consider putting in something that we call an Ivc filter. And that's a filter that sits in the inferior vena cava, and if there's clots that actually migrate up, that particular filter will catch those clots. So does that answer your question? Yeah. Okay. Good questions. Good questions. Oh, no. Okay. So surgical management, that's kind of the approach that we take. And this is the one thing that we do different that most other institutions do not. Liver transplantation or possible liver small bowel transplantation. Again, this is a very specific treatment option for a small group of individuals. Liver transplantation can be offered to everybody, because we have to be able to know with 100% certainty that this particular cancer or neuroendocrine disease has not migrated outside of the liver. It's all localized in one location. Why? Because liver transplantation can lead to you suppress the immune system and it will result in reoccurrence. And if the disease is outside of the liver, it will make that metastatic disease that's already outside of the liver worse. The reason being is because you suppress the immune system. You suppress the immune system, and then these lesions that were subclinical before will just all of a sudden blossom. And then here you've done an operation and you've taken an organ outside of the donor pool and you've given it to somebody, and you know what, they've got recurrence within 6 months and their disease is just out of control. And that's not what we want. So we're very, very strict when it comes to offering transplantation. These are individuals that, again, have disease localized to just the liver. Their primary disease has been controlled, and we've been able to watch them for at least 2 years to show that the disease has not migrated or come up in other parts of the body.
What does that mean, control?
What's that?
What does that mean, control?
Controlled. So we need to show that the disease is only in the liver. And that's the only spot. Because what we want to be able to say is that we'll take the liver out and you don't have any cancer.
So we have to be able to find a primary site. You know, like
Yeah.
Dr. Vargas said, sometimes you haven't been able to find that primary site.
Yeah.
But to be eligible for a transplant, you have to know for sure where that primary tumor's from. It's been removed,
Yeah.
and 2 years' time's passed, and as he said, there's no evidence of anything
Yeah.
outside the liver.
So in other words, you're considering the primary tumor to be in the liver?
No. So what we need to know is that if it was from the small bowel's out, the tumor from the small bowel is out, and then your disease is only in the liver. And I'll even take it a step further. If a person comes to us and you know what, they've got diffuse disease, but you know what, they're functioning very well. You know what, they don't have any of the sequelae of liver dysfunction, their symptoms are minimal, they're getting around without any problems. Transplantation is not going to help this person. Transplantation, because this person is doing well with their disease right now. So let me give you a particular scenario. So scenario would be somebody that had their primary resected, and all they have is metastasis or localized disease in the liver, and we've treated them. You know what? They've had clinical symptoms of carcinoid, flushing, diarrhea, whatnot, and we've started treating this diffuse disease with, say, chemoembolization. We've embolized the liver multiple times, and now we've embolized it so much that this person's actually feeling the effects of liver insufficiency, because chemoembolization doesn't only knock out the tumor, to some degree it'll actually knock out some of the normal liver tissue. But the way we get away with it, it's because the liver is able to regenerate. So in that particular situation, that person's undergone multiple chemoembolizations and they've continued to have symptoms, but yet their disease is only in the liver. Now, after so many chemoembolizations, they're starting to get portal hypertension. They're starting to develop some ascites. They're starting to develop some cholestasis. The bilirubin's starting to go up. Because, as you know, most patients with liver disease, their liver function actually works pretty well. You can have a liver riddled with tumors, but you know what? The person's doing fine. But so that would be kind of one scenario, one specific scenario that comes to mind where, you know what, this would be a person that we'd consider for transplantation. So, and on top of that, so the person also has to actually be fit to tolerate a transplantation. So this is a very small group of individuals, but again, this is something that, you know what, some people are out there that fall into this.
So because neuroendocrine tumors are so slow growing, how did you pick 2 years from initial resection in the bowel to transplantation?
We roll the dice.
So in other words, we don't really know what the scenario will be. You could have a reoccurrence at 2.5 years and you've gotten your transplant.
Yeah.
I mean, so there's definitely
Yeah.
some real thought process that has to go through having a liver transplant
Yes.
in this whole process.
Exactly. So from our standpoint, we feel comfortable saying that, you know what, we've watched this tumor. So you've gotten at least 4 scans in that interval, and we need to be able to show that, you know what, that disease has not changed. And again, like I said, it's not just the scans. It also has to do with the other things. Has this particular patient started to show signs of liver failure from this and stuff? But like I said, this is a very small subset of patients.
Well, I think you've just described my wife's situation.
Yeah.
Because she has what they call like pinhead-sized tumors, and it's perforated all through the liver.
Yeah.
And they haven't found her
Primary.
primary, and they think they know where it is.
Yeah.
And other than that, it's nowhere else
Yeah.
that they've found, and she's feeling good, except the reason she's not here today is because every once in a while she has what we call an attack,
Yeah.
and where she gets this terrible stomach cramps
Yeah.
and a terrible backache, and then
Yeah.
when it finally subsides, she's just totally wasted. She's just
Yeah.
like all her energy's gone.
Yeah.
And so, I mean, that's what sounds like you're explaining.
Yeah, but in that particular situation, the primary needs an exhaustive approach should be found. Like, I'm talking like diagnostic laparoscopy, diagnostic laparotomy, or a person, you know, we need to know where that primary is, because if you really think about it, unless it was a liver primary neuroendocrine tumor, which is also very rare, if you haven't found that primary and you do a transplant, that liver is just going to get diseased again.
So if the primary's found,
The
and then
primary's found
removed,
and removed,
and then you wait
and then you wait.
to see if it comes back,
Yeah,
then you could possibly do.
you could possibly. Yeah. Again, I don't want to sell this that, you know what, this is the end-all, save-all with regards to neuroendocrine disease. Like I said, I want to be very clear that this is a very small subset of patients. Yeah.
But the procedures that you were talking about are mostly for larger tumors,
The ALPS procedure, you mean? Or
the
stage
removal
procedure?
of the tumors in the liver.
So, yeah, it doesn't, okay, so for larger tumors, as long as we can, so the whole goal with regards to resection is to take at least 90% of the tumor disease out. That's the whole goal with regards to the resection. That's our goal. So larger tumors, medium-sized tumors, smaller tumors, you know what, we'll take them out. But what I want to emphasize is that, you know what, if a person comes and they've got both what we call bilobar disease, in one lobe or the other, and the tumors are small and clinically they're doing well, from my standpoint, it'd be what an operation's not. Sure, we can take more of the liver out and we can say, okay, you know what, you instead of have 80% of your liver with these small, tiny little ditzels, now you have 35%. Am I going to really make a difference with regards to the way you feel, to the way how active you are? I'd have to look at it long and hard, but my first impression would be no. You know, as much as I would like to say, you know what, I've taken all the tumor out, sometimes that's not necessary. As you know, this disease is very indolent, and sometimes intervention can cause a lot of problems. It can. And again, like I said, liver transplantation is a huge intervention, huge. They can cause a lot of problems if not applied to the right patient. Again, it all has to do with patient selection. That's what it has to do. So again, I just want to emphasize, this is not for everybody. Again, I would say it's for a very few set of people, but again, it's something that we do offer. Any other questions? Sure.
What percentage tumor load can you tolerate before your liver starts, before your liver can provide
What it needs to? I can't. I can't give you a number with regards to percentage-wise, but what I can tell you is what you should look for if you notice these problems. What you should look for is my INR going up, because again, these are particular proteins that are produced by the liver. Is my bilirubin going up? Am I developing fluid inside the abdomen, this ascites? Do I have any problems with confusion? Again, we're all kind of confused at some degree depending on the day. But something that your physician can tell you, are you developing what we call encephalopathy? These are all signs of what we call liver failure. But like I said, the liver has an uncanny ability to regenerate. So yeah, we don't look at it as, so from my standpoint, I don't look at scan and say, okay, you know what, this liver has 85% tumor and I'm worried about the liver function. And I'm more worried about the 85% of the tumor, not necessarily the liver function, because that is something in my mind that says, you know what, I need to decrease that bulky disease, either with chemoembolization, with surgery or something. So that disease needs to come down, that amount of disease needs to come down. So yeah.
It's pretty uncommon that we see patients that have signs that their liver's failing.
Yeah.
It's more common that we see patients who have the signs and symptoms of carcinoid syndrome.
Yeah.
So
What are you worried about though? Tell me, so that's a question, but what are you worried about with regards?
Well, what I'm worried about, I've got, the doc told me 45 to 50% tumor load.
Yeah.
And I certainly have the side effects. And
Side effects of the tumor or the liver? Inadequate liver.
It started in mid-evening,
Okay.
and it had already metastasized to the liver.
Okay.
And I had heart bypass surgery, and there was even a tumor on the heart, which they removed.
Okay.
And so when I hear you, my blood pressure goes up, and I keep thinking, first of all, do no harm.
Yeah, that is the truth. So that's where these other interventions come into play. Like, again, surgery is a big harm. It's a big undertaking. And this is where these transarterial chemoembolizations, gland embolizations come into effect. Because again, people can tolerate these procedures a lot better, especially if they're more mature with regards to on operation.
One more question.
Sure.
You told me that my tumors are, I think, are in half the liver.
Mm.
And what's wrong with just surgically removing the tumors from there?
In general or in you?
I'm concerned about me.
That's quite all right. We all are. So, not knowing you, but based on what you just told me, you have heart disease. So you'd have to go through a whole. You have to weigh the pros and cons. One, the biggest pro would be, you know what, you get rid of the disease. But on the other side of that is like, well, what risk are you taking to take that on? Well, I'm at risk for a heart attack. I'm at risk for a stroke. Am I at risk for being on a breathing machine indefinitely, renal failure? And you know what? You're here with us today. So that's where the whole discussion comes in. It's like, you know what? As much as we can do these operations, some people, just based on where we catch them in life, are not candidates for this stuff.
Here I think, here I'm already 85 years old, and I've had a full. Should I be happy because I lived so long, or should I be sad because I'm got this disease?
I would be happy that you lived so long. I would be happy. You know, some people don't even make it to 80 for crying out loud. You know, it's the truth. It's the truth. But again, the one golden thread through all of this is that, you know what? Current management of neuroendocrine disease has allowed us to make this a chronic, change it from something that, you know what, people were dying from quickly to something that people can deal with. Just, it's a chronic disease. So I'll get to that. So chemotherapy. Chemotherapy is not my bag of tricks. I will just let you know. So chemotherapy is not my bag of tricks. I will just let you know. So if you're going to ask me specific chemotherapy regimens, I'm just going to say pass. I will talk to my oncologist because she's the one that comes to us, to treating primarily like cytotoxic medications and stuff. We use a lot of octreotide. We don't use much of lanreotide or the pasriotide.
Why not?
It's just preference. It's our preference. This is what we do.
I wasn't on Cryotherapy, and for some reason, the doctor put me on lanreotide now. I'm wondering why.
That's just our preference, that we use octreotide and stuff. Again, these somatostatin analogs, the whole approach is that, you know what, they bind to the receptors on these neuroendocrine tumors. There's 5 receptors, 1 through 5, and based on the particular type of medication, they have specific affinity to those particular receptors. And here you can see octreotide and lanreotide, primary 2, 5, plus minus 3, for pasriotide 1, 2, 3, and 5. You have angiogenesis inhibitors. You have sunitinib and bevacizumab. This is Avastin. It's a chemotherapy drug used in colorectal cancer. These are going to just inhibit blood flow formation, interferon, and then other cytotoxic drugs, temozolomide and streptozocin. These are what we call alkylating agents. They bind to DNA and disrupt DNA production. Again, neuroendocrine tumors divide very slow, so these particular agents don't work very well for those. But again, there's been shown some evidence that there's some response, but nothing like we would hope.
Could I ask one more question? Sure. I don't want to be the only one doing the talking, but on lanreotide, can I still use the sub-Q octreotide for a rescue?
To tell you the truth, I do not have a lot of experience with the lanreotide, to tell you the truth. I do not.
Well, I've done it, and I'm still here.
I imagine you've done a lot of things. But yeah. And again, I don't want to speak out of terms either, give you wrong information. So I'll just pass on that one. PRRT. So this is peptide receptor radiolabeled therapy. As far as I know, we do not offer this in the United States. This is something that's primarily done overseas. This hasn't reached approval through the FDA, unless other people are doing it here that I don't know of. Anybody doing PRRT in the States?
Texas.
Really?
Texas is
Houston, right?
Yes.
That's right. That's
and
right.
we had a couple of patients who looked into being included in that
I don't.
PRRT
Yeah.
trial or in Houston, and
Really?
and they were
Oh,
ruled
wow.
out.
I just looked at
it seemed to be a lot of roadblocks
Really?
to be able to get into
I
it.
just had my first one about
Wow.
7 weeks ago.
So here, hold on. Let's,
Texas human use?
she's mad.
At Mayo. I just had my first one about 7 weeks ago.
What? And that's brand new info.
So here's PRRT. So what PRRT is, you probably know, It's binding the octreotide to a radioactive nucleotide. Initially it was done with indium, but the results with indium, there was some benefit with regards to symptoms, but there was no radiological response. But as of late, they're using yttrium and lutetium as the nucleotide. And they've seen some response with regards to radiographic findings with these two particular isotopes. So again, the whole goal is that this octreotide will actually bind to the receptor, and since this octreotide is actually bound, it's actually going to provide some radioactive effect to that particular tumor. So, and this is something that, again, unbeknownst to me, is now being offered as on trial basis. It's not on trial basis. It's not being offered as straight therapy and stuff. So outside of a clinical trial, you will not be able to get this. And then again, trials. This was, actually, I just looked up in clinicaltrials.gov, and I didn't see that one. That's interesting. I looked it up. And
There are several sites in the U.S.
Yeah. So this is actually just coming off of clinicaltrials.gov, and this is as of 10 minutes ago. When I type in PRRT, this is what comes up, and this is people out of Brussels. This is not. I'll just have to refine my search and see. But yeah, that's interesting. And conclusions. So like I said, cancer is an uncontrolled growth of abnormal cells in the body. Disease is a disorder in the structure or function of the human body that produces specific signs or symptoms. And as I've said, neuroendocrine cancer is difficult to eradicate. The current management has allowed us to change neuroendocrine cancer to essentially becoming an indolent and chronic disease. So what we tell our patients, our goal is to make this disease or make this cancer more of a nuisance than a hindrance. In the sense that our goal is to provide symptomatic care, resect when we need to, treat when we need to. But what we want our patients to do is just live productive lives. And sometimes that may not require a resection. And I think this is what we try to stress to our patients. When people hear cancer, and everybody, include the media, people that you know, everybody's knee-jerk reflex is that it needs to come out. It needs to come out. That's what everybody feels. But you know what? With neuroendocrine cancer, sometimes it can. But if it stays in, our goal is to control it. Our goal is to control it. So, questions? And
yes.
So this is the CAT scan that we first saw, again, all the right lobe. And now this is where we've actually taken that tumor out. I was going to put his picture, but I didn't ask his permission.
Oh.
So, any questions? Sure.
Yeah, okay, so we're operating under misconception perhaps
What do you mean?
with Ruth. You know,
Such as?
Ruth has been very public.
Yeah.
And what she'd always say was, Dr. Bolton took out one lobe of her liver, allowed it to grow back, and then took out the other one to grow back.
Yeah. Well, Ruth is not a surgeon, not a. So from her standpoint, this is what. I don't know if I'm violating HIPAA.
I thought that too, but Ruth has been very public, and she's been published with this. She's on the internet. You can look up her whole experience.
Yeah. So, okay. So I'll, without mentioning any names, I'll just tell you, when we do a stage resection, we look at both. So we'll divide the right into the left lobe, and if there's bilobar disease, and we can get rid of disease in one lobe, we'll get rid of it, and then, if possible, we'll come back, let that particular lobe that had disease in it grow, and then we'll come back and take out the other lobe. So, like I said, you can never have both lobes taken out with the exception of the transplant. What will happen is that one lobe will grow, and then we'll take the other one out, and that's what will be left. So here you can see this. So here you see the right lobe, and look how small this particular sliver is. You see that? So, like I said, we'll take out, if there's any disease here at the time of the first operation, we'll take that disease out with the thought that, you know what, that lobe is going to be left behind and there isn't any disease left. Because there's no way that we can debulk this disease on the right side short of taking the whole thing out. So just to, again, to emphasize.
Isn't that part of the misconception? It's you're not removing a lobe. It's language. It's a wedge. It's a segmentectomy.
Yeah.
It's a sharp bite.
Yeah.
You're doing a very localized tumor excision
Yeah.
within a lobe.
Yeah.
So you're taking out the leaves of a tree,
Yeah.
leaving the branches intact,
Yeah.
while you're waiting then for it to grow.
Yeah. Here,
To
let me
fill
do-
up proportionately to allow you to completely do a complete lobe resection.
So Dr.
Those are
Volker
very
was just
different
saying,
things.
it's not like a lizard's tail. That part, that lobe that you wind up taking out at the end does not regrow like a lizard's tail, but that part that's left behind that's healthy and now tumor-free is going to grow big enough to be the size, pretty much the size that it was before.
Unfortunately, the lighting is not that great, but here you can see, so this right here would be the division, the plane of division for the left lobe here, and then the right lobe here. So there's a lesion here, and if I was able to scan through that CT scan up and down, I would show you another lesion here, and you can actually see a lesion here. So you see lesion here, there would be lesion here, there would be lesion here. Let me just turn them off. There we go. So here's a lesion actually pushing on what we call the vena cava, right there. There's a lesion there, and then if I were able to scroll up and down, I would show you another lesion here. So this is, again, the division. This would be the left lobe here. Now, here's the right lobe. So there's lesion here, and when you scroll up and down, there's another lesion here, and then lower down, there's another lesion over here. So these are large tumors. So in this particular situation, my plan is to do a staged procedure where I would take this out, take the other lesion out here, take the other lesion out here, and then come back and then take this out. Because when I come back the second time, this part of the liver that has no identifiable tumor will grow. And that's when it grows what will allow me to take it out safely. Because like I said, you take too much liver out, people will go into liver insufficiency and liver failure. And that is not something you want to do to a person that has indolent disease. So to your statement and comment, yes, that's what it essentially is. You can take a segment. So there's 8 segments of the liver. Some people argue 9. You can take one segment out. You can do wedge resections. You can do a caudate lobe resection. But you do not take out both lobes of the liver. You do not. When you look at it, it's pretty impressive what the liver can do. It really is. It really is. So, but yeah, back to your point. You cannot take both lobes out. You cannot. Because if you take both lobes out, well then you, like the other picture I was showing where you see the portal vein going into the right side and the left side, to really take a lobe out, you divide the inflow, the portal vein and the artery. So yeah. Sure.
So what do you do in Nebraska that's different than they do at other carcinoid surgery centers?
I just want to put it on my kids. I haven't seen it. Again, it's the transplantation caveat. I think that's the biggest thing. And then the stage resection. Again, just due to my training and my mentor, I'm very comfortable dealing with the liver. And I tell patients, I can take a liver out and put it back in. That's usually enough for me to tell them, okay, we're pretty comfortable with you. So again, the biggest thing, what makes us different is the people. Come on. But no, seriously, I think the biggest thing is it's the transplantation, because not many centers can offer that. Not many.
How many transplants do you do a year?
On average, we do probably 100, high 90s to 100, but for straight carcinoid.
For neuroendocrine carcinoid?
So like I said, for neuroendocrine, I would say we've done this, say, for the last 3 years. No, take it back, the last 5 years. I'd say we're probably in the low teens. So like I said, this is not an option for everybody, but it's an option for those people that have nothing else and stuff. So that's the thing.
And you know, we tell everybody, anybody who comes to us for a liver transplant for any reason, you're really kind of trading one set of problems for another when you get a transplanted organ, because that's a life-changing event.
Yeah.
You know, you have to have monitoring your blood tests on a regular basis. You're at risk of other issues because of the immune system that we're trying to suppress, and so, you know, it does have to be a pretty unique situation.
And like I said, this is not for everybody. It's only for a very, very select few. So, yeah. Sure.
What percentage of neuroendocrine tumors metastasize to the liver in general? Do you have any numbers on that?
So metastasis. So the rate of metastasis is related to the actual size. The larger the tumor, the higher the likelihood. Usually. But there's a large, doesn't have a lot of comorbidities. That'd be an individual that I'd say, okay, it's worth taking out. If you have a tumor that's about that size sitting in the head of the pancreas, this is where it's, you know, we can, and they have multiple comorbidities, this would be a person that I'd probably watch. Again, it all has to do with the pancreas. It has to do what you're trading. You trade the operation, complications from the operation, from the risk of metastases.
How about a mesenteric tumor?
Mesenteric tumor, I would probably be a bit more aggressive, just because if it's in the small bowel, I would be aggressive with it in a sense, try to take it out. But if it's in the mesentery, near the mesenteric vessels, now that's a different situation, because you can have a small bowel primary that has metastasized to the lymph nodes, and for some reason they have a nasty habit of actually getting close to those mesenteric vessels, and it causes a very intense, what we call a desmoplastic reaction, kind of scar tissue formation around those vessels that makes it difficult for them to take out. And sometimes it actually, what we call, encases those vessels, and where the operation is going to cause more problems. So just imagine, say, a tumor 3 centimeters in size, and then all of a sudden all the blood vessels that go to the bowel actually go through that mesentery. That would be somebody, you know what, we're going to take a wait and watch type of approach. Now if it's just in the small bowel and they found it on routine endoscopy, I would say, you know what, it's worth taking out, just because of the risk of that operation are somewhat small. But now if you have somebody with multiple comorbidities where they're not going to be able to tolerate anesthesia, and they're more mature, I would say, you know what, let's watch, just because I think the risk of the operation can be a problem. So that's the way I approach it. So. Does that answer your question? Not really? You want specifics, I can tell. Give me the specific situation.
This is about my dad, who has a mesenteric tumor, and some of what you talk about, the location and things, I'm not.
Yeah.
I don't
So
know
when people say mesenteric tumor, that's usually that it's probably a small bowel primary that's traveled up into the lymph nodes near the mesenteric vessels, and it's stuck there. If you catch it early enough and it's not involved in the vessels, you can chisel it out. But there's been often times where it's not, and it's actually encasing those vessels. And to take it out would require to disrupt all the blood supply to the intestines, and that's just not.
Is it equally complicated to identify whether or not that's the primary tumor?
What do you mean? The mesenteric or the?
Right.
I would say that's probably not the primary. I'd say the primary came from somewhere else. I'd say that's probably lymph node metastases. That's what I would say. Question?
Yeah. About 7 years ago, I was diagnosed with carcinoid. Never found primary. Is that unusual? Is it?
Yeah, it
I
is.
mean, I don't have it? What does it mean?
Well, it's unusual, but that's okay.
I've always been.
It's okay. Like I said, you know what? Everybody's different. This neuroendocrine disease is different with some people. Some people are lucky enough where, you know what, they had a 14-centimeter tumor, now metastasis. They had an unknown primary. It's never
I have
given
all
up.
the symptoms.
Yeah.
Okay.
Okay. But how about the So.
We've had a couple of patients that we couldn't find a primary tumor on. One, they did wind up finding it on a gallium scan,
Yeah.
and it was a small bowel primary, but all the testing that had been done to that point didn't identify it. We've had one person, I think, that they found the primary in the small bowel after the MR enterography. But, I mean, we've had a couple of patients, so it was quite a challenge. And we have a couple, I think, that it's never been identified yet.
Any other questions?
Do you think it's inherited?
There's some risk. There's some inherited risk. Primarily like the pancreatic functional ones, like leukocytoma and insulinoma. There's some genetic predisposition.
How long does it take, if you do this whole thing, 6 weeks later, how long does this put you on commission?
It depends. Like I said, somebody that's 20, be out of commission for
20 years?
Somebody that's 85. And like I said, you know what? Somebody just based on our little conversations, it sounds like you're doing okay. And my recommendation would be, you know what? Okay is not bad. Yeah, okay is not bad. All right. Well, thank you, everybody.